Trismus. Published by NCBI. Continuing education activity. Trismus is commonly referred to as lockjaw and is usually due to sustained tetanic spasms of the muscles of mastication. Although it was initially described in the setting of tetanus, it is now used to refer to a bilateral restriction in mouth opening from any cause. This activity reviews the evaluation and management of trismus and highlights the role of interprofessional team members in collaborating to provide well-coordinated care and enhance patient outcomes. Objectives. Identify the etiology of trismus. Evaluate the presentation of a patient with trismus. Differentiate the treatment options for trismus. Communicate the importance of enhancing care coordination among the interprofessional team to ensure proper evaluation and management of trismus. Introduction. Trismus refers to the restriction of the range of motion of the jaw. Initially described in the setting of tetanus, it currently refers to restricted mouth opening due to any etiology. It is usually temporary and typically resolves in less than 2 weeks. Still, permanent trismus may also occur, interfering with everyday activities such as speaking, eating, and swallowing and complicating oral hygiene and the delivery of dental procedures. 1, 2. Etiology. Multiple conditions can result in trismus. Acute trismus may be caused by facial, mandibular, or iatrogenic trauma. Examples of iatrogenic trauma include third molar extraction and intramuscular administration of anesthesia. 3. Acute trismus from iatrogenic causes tends to be self-limiting. 3. Severe trauma usually causes chronic trismus. 3. Chronic trismus may arise from temporomandibular disorders, neoplasia, surgery, radiotherapy in the head and neck for managing cancer, local infections, and connective tissue disorders like lupus erythematosus. 3. Trismus as a complication of local anesthesia. Trismus is a possible complication of the inferior alveolar nerve block. During the administration of this block, the masticatory muscles, mainly the medial pterygoid muscle, can be accidentally penetrated, resulting in pain-related trismus. When the affected muscle stretches, it triggers pain, causing immediate reflex contraction and mandibular opening limitation. 4. Trismus may also arise when an intramuscular hematoma occurs. 4. Injury to the inferior alveolar artery or vein may lead to hematoma in the pterygomandibular space, resulting in trismus. 4. Trismus after 2 to 3 days of the injection is most likely caused by a needle tract infection. 4. Trismus as a complication of dental extractions. Pain, trismus, and swelling are common complications of the surgical extraction of mandibular third molars. 5. Such complications result from the inflammatory response to surgical trauma and are classically short-term. 5, 6, 5. Trismus as a complication of trauma to the face and mandible. Fractures, mainly mandibular, may result in limited mouth opening. 1. Although rare, fractures of the zygomatic arch and zygomaticomaxillary complex can cause trismus as they impede the movement of the coronoid process. 1. Trismus as a sign of temporomandibular disorders, TMD. Temporomandibular disorders refer to the dysfunction and pain of the mastication's temporomandibular joint, TMJ, and muscles. 7. TMDs typically cause facial and preauricular pain, functional noises in the TMJ, and limitation in mandibular movement. 7. Therefore, many patients reporting limited mouth opening likely have a TMD. Myofascial pain and disc displacement without reduction are 2 common types of TMD that may cause trismus. 8. Trismus as a complication of dental infection. Dental infection must be suspected in patients with acute trismus, as severe dental infections involving the masticatory muscles often cause trismus. 9. These infections can extend into the head and neck spaces and result in life-threatening complications, like mediastinitis and cervical cellulitis. 1. From the infections of dental origin, pericoronitis is more associated with trismus. 1. Examples of infections from non-odontogenic sources that may trigger trismus include tonsillitis, parotid abscess, tetanus, meningitis, and brain abscess. 1. Trismus as a sign of malignancy. Patients with limited mouth opening and pain in the preauricular area are likely to be diagnosed with TMD. 10. However, although less common, trismus may also be caused by malignancy. Trismus rarely presents as the primary sign of malignancy, but it should not be ruled out. Cases of misdiagnosis of trismus as TMD leading to delayed diagnosis of malignancy have been described in the literature. For example, a case of a 62-year-old patient presenting with severe trismus and TMJ pain was misdiagnosed as having a TMD and underwent treatment but was found to have adenocarcinoma of the temporal region a year later. 10. For this reason, a specialist TMD clinic has developed a checklist to identify trismus cases with atypical features. 8. If a patient presents with the following 5 signs and symptoms, radiographs and referral to a senior clinician must be considered. 8. 1. Opening less than 15 millimeters. 2. No history of clicking. 3. Pain of non-myofascial origin, e.g., neuralgia. 4. Lymphadenopathy. And 5. Suspicious intraoral soft tissue lesion. Trismus as a complication of head and neck cancer treatment. Trismus is a common side effect of head and neck cancer and its treatment. 11. According to recent studies, it develops in 38% to 42% of head and neck cancer patients. 12. 13. The TMJ or the mastication muscles can experience fibrosis because of radiotherapy, leading to trismus. 11. The trismus risk increases when the medial pterygoid muscle is in the radiation zone. 14. Furthermore, surgical procedures to treat head and neck cancer can scar the mastication muscles and restrict mandibular opening. 15. Classification. Multiple conditions can result in trismus. Some authors classify trismus according to the involvement of the TMJ in intraarticular and extraarticular etiologies. 2. Others have categorized the causes, such as infectious, traumatic, and neoplastic sources. 1. Trismus may also be iatrogenic, resulting from prescribed interventions and treatments. Below are some of the conditions associated with trismus. Traumatic. Hemarthrosis, hematoma, fracture or dislocation of the mandible or zygomatic arch. TMJ contusion, intraarticular bone islands, foreign bodies. Displaced meniscus, direct injury to muscles of mastication. Inflammatory. Osteoarthritis, soft tissue fibrosis, TMJ ankylosis, rheumatoid arthritis, scleroderma, temporal arteritis. Infectious. Pyogenic arthritis, osteomyelitis of the mandible, tonsillitis, paratonsillar or other pharyngeal abscesses, tetanus, odontogenic abscess, mumps, parotid abscess. Congenital malformations. Pierre-Robin sequence, trismus pseudocamptodactyly syndrome. Head and neck neoplasms. Pharyngeal carcinoma, parotid gland tumors. Odontogenic. Impacted third molar, or following extraction thereof. Iatrogenic. Perioperative inflammation, radiotherapy for head and neck cancer. Neurogenic. Tetanus, status epilepticus, Parkinsonism, strychnine, phenothiazine poisoning. Medication adverse effects, phenothiazines, metoclopramide, tricyclic antidepressants. Hypocalcemia, hypomagnesemia, respiratory alkalosis. Psychogenic, conversion disorder. Epidemiology. The prevalence of trismus ranges widely, partly because no clear criteria have been established, and depends on the inciting etiology. Importantly, trismus is a common finding in certain patient populations, such as those with congenital micronathia syndromes or undergoing radiation therapy for head and neck cancers. 16. 17. It can also be a rare complication of common conditions, such as pharyngitis. History and physical. Normal mouth opening ranges between 40 to 60 centimeters, 2 to 3 finger breadths, and many authors consider a maximum mouth opening of less than 35 millimeters trismus. 1. However, it varies from individual to individual, and even according to sex. Males generally feature a wider mouth opening. 1. Patients presenting with trismus note a restricted mouth opening and sometimes pain when attempting to open the mouth. However, patients often complain about the causative condition rather than the resulting trismus. Those with odontogenic etiologies may complain of tooth or gum pain and swelling. Patients with traumatic causes may note facial or mandibular pain. A complete clinical examination should be performed to identify systemic causes. Fever may indicate an infectious source. Weight loss may be notable among patients with neoplastic causes. Carpopedal spasms and paresthesias may accompany trismus in patients with neurogenic or metabolic causes. A history of tobacco use or known cancer could raise suspicion of a neoplastic cause. 1. During a physical exam, a trismus may also be encountered when attempting to visualize the oral and pharyngeal structures. This challenges the examining clinician's attempt to ascertain the cause of trismus. The exam should be targeted as much as possible to the teeth and gums, facial bones and TMJ, pharyngeal pillars, tonsils, uvula, and neck. Assessment of the patient's speech may be necessary. Some pharyngeal infections implicated in trismus may also cause changes in the patient's voice. A hot potato voice may be associated with tonsillitis or peritonsillar abscess. A directed neurologic exam should be performed to evaluate for neurogenic causes. 2. Evaluation. The diagnosis of trismus is mainly clinical. Imaging adjuncts may be useful in determining its etiology and the TMJ's articular involvement. Computed tomography can help to identify traumatic etiologies, including hematomas or facial and mandibular fractures. Magnetic resonance imaging may identify space-occupying lesions or abnormalities in the pharyngeal or oral structures. Treatment, management. Treatment of trismus is directed at the inciting etiology and is most commonly managed symptomatically. Symptom-directed interventions, including heat therapy, analgesics such as non-steroidal anti-inflammatories, NSAIDs, and muscle relaxants, are usually prescribed in the acute phase and are the mainstays for treating uncomplicated transient trismus. Heat therapy includes applying moist hot towels for 15 to 20 minutes per hour. 1. When it comes to analgesics, aspirin is usually sufficient. 1. When a muscle relaxant is needed, a benzodiazepine, such as diazepam, is recommended with a dose of 2.5 to 5 milligrams 3 times per day. 1. The clinician should also encourage a soft diet for the duration of the pathology. 1. Further dental treatment must be avoided until the trismus resolves. 18. Usually within 48 hours of initiating treatment. Stretching exercises may be indicated after the acute phase or in patients with post-traumatic and post-operative trismus, particularly when persisting longer than 1 week. The exercises typically involve repeated attempts to open the mouth against applied resistance, usually divided into multiple daily sessions. 11. Physiotherapy includes opening and closing the mouth and lateral movements for 5 minutes every 3 to 4 hours. 19. Sugar-free chewing gum can be indicated to stimulate lateral movements. 1. Physical therapy alleviates edema and fibrosis, restores blood circulation, improves range of motion and muscle strength, and keeps the muscle active. 3. Trismus may become chronic in the setting of fibrosis or ongoing radiotherapy. These cases may benefit from intensive physiotherapy, sometimes utilizing commercially available jaw motion rehabilitation devices or microcurrent therapy, particularly in patients refractory to more conservative approaches. Some authors have also described treatment with xanthine derivatives such as pentoxifylline. 1:20. If trismus does not improve after 2 to 3 days, or in cases of extreme trismus, referral to an oral and maxillofacial surgeon should be considered. 1. Extreme trismus cases that are repeatedly refractory to treatment require surgical procedures, like reducing the mandibular height to achieve a larger mouth opening, coronoidectomy, or tissue release and free flap reconstruction. 11. Differential diagnosis. Since trismus has been defined as a restriction in mouth opening regardless of etiology, it does not have a wide differential diagnosis. Some authors have argued that true trismus is mediated via the trigeminal nerve, and intra-articular causes of impaired mouth opening, such as TMJ ankylosis or fibrosis, should be considered separately. 1. Others have outlined such intra-articular processes as subclassifications of trismus. 20. Prognosis. Trismus is most commonly self-limited and transient, typically resolving within 2 weeks. However, in certain cases, like patients who develop fibrosis from radiotherapy, the course of trismus may be longer and refractory to conservative treatment. 17. Complications. Trismus interferes with speaking, eating, and swallowing. It has also been associated with aspiration due to impaired swallowing mechanisms. Intubation via the oropharyngeal route may be impossible in patients with significant trismus, necessitating other approaches such as nasopharyngeal intubation or tracheotomy. When its duration is prolonged, it leads to TMJ fibrosis, necessitating directed therapy. 20. Consultations. Consultation may be considered based on the suspected etiology. Dental or oral surgery care may be enlisted for odontogenic causes, while an otolaryngologist is sometimes consulted for peritonsillar abscess drainage. Physiatrists may also be involved in a patient's care when directed therapeutic interventions are necessary to treat refractory trismus. 1. Deterrence and patient education. Patients should receive counsel to rest their jaws, avoid activities like nail biting and teeth clenching, and, in certain cases, work with a physical therapist on jaw muscle strengthening. Pearls and other issues. Key facts to keep in mind about trismus are as follows. Trismus most commonly occurs in uncomplicated common conditions, e.g., wisdom tooth extraction. It may also be a common complication of uncommon diseases, fibrosis following head and neck radiotherapy. Trismus is best addressed by identifying the inciting etiology and directing treatment to the underlying cause. Most cases of trismus resolve following symptom-directed treatment with heat therapy and NSAIDs. Refractory chronic trismus may require physiotherapeutic interventions. Implementing a checklist to identify cases of trismus with an atypical presentation may help identify cases of malignancy at early stages. A specialist or physiotherapist usually prescribes mandibular opening devices.